So once we saw what our peer staff could do, we realized we'd set the bar way too low. And their capabilities and effectiveness began to make a big difference throughout our organization and even the entire system. Our peer staff helped us shift from focusing on problems to seeing the possibilities because they knew it from firsthand experience. And so this is profound because we were talking earlier this afternoon about too often when people come to us, we have to diagnose the problem. And by golly, if it's not big when they come in the office, it's pretty big when they leave, you know. The peer staff aren't trained in problems. We don't train them in diagnosis and to do mental status. We've got that. We've got that down, you know. They're trained in possibilities. They're trained in potential. And so they helped us begin to shift our conversation. They had higher expectations than we did. They believed that people could recover. And they were more apt to say, I know what you mean, and do that with credibility. They would say, I've been there. They would say, we can get over this. The message of hope. So as this began to grow, we were thrilled and excited, and we were just busy doing all this stuff, and sometimes we were too busy to even count the numbers, but all of a sudden we realized that over the years in Maricopa County, which is the Phoenix area, there had been roughly 850 people that had graduated from the training program, but that 75% of them had been employed as peer specialists. And for some, this became a new career. For others, they chose to move on to some other field of interest, right? But they began to have some success in their life and in their work. Since we started, through June of 2009, 546 peer specialists have been employed in our Arizona program. And this has grown now to other programs that we're delivering in other states. 100 have been employed in other organizations, so we're not training them just to work with us, but also throughout the mental health system. Today, 247 peers are currently employed in the Arizona program, which represents 72% of our workforce. Many of them are in full-time jobs. Now, I didn't set out to do this strategically, deliberately, but it's what showed up because it's what was working and it's what was making a difference. And every time there was an opportunity to redirect some funds or some new funds became available, this is what was funded. So we had more opportunities to continue to grow the peer support work. The other people, the other professionals and other mental health staff didn't go away, you know, but we continued to grow the peer workforce. Again, 91% of our current, this is people employed of the 247, 91% have been employed for at least a year, and over 50% have been employed for 3 years, and that's much higher than that because that 3-year period was they haven't started working prior to 3 years ago. 73% of this group are in leadership positions. A couple of them as CEOs of other organizations in our community. These were people that had been told that they would never work again and had spent years lying on their sofa in their living room. You know, in fact, our regional vice president, Lisa, of our California programs, is someone who was told exactly that. And she had no life whatsoever. But now she's working at a very responsible level, making a real contribution in the Southern California system. Another thing that was so exciting is that $4 million of compensation of salary was being paid to this group of employees that was previously going into mental health treatment. These were mental health dollars that were now going into their paychecks to improve the quality of their life. I think that's really cool. So some tips that we've learned over the years. First of all, we have to have real commitment. That has to be a commitment from the organization, a commitment from the leadership to really make this work. Because it does challenge many things. I mean, we've had rules that get in the way of this being able to work. One organization I'm thinking of in Tucson, I mean, they literally had in their HR policies that somebody with a mental illness couldn't be employed, and I've heard rumors of similar things in other places. Employed in their organization, right? We've got to have quality training. I've been talking about that. We've also got to have training for all staff so everybody understands what we're doing and why we're doing it to really embed this new discipline of peer support. We've had to do supervisor and leadership training. Now, this was really interesting because we were asked by the state of Pennsylvania to be a vendor throughout the state as they implemented their peer support initiative. And one of the things they required is that anybody that was going to supervise a peer specialist employee had to go through a special training for that. So we kind of scratched our heads and said, well, what is that like? And yeah, there are some things we need to talk about, for sure. But what we started to realize is this really just needed to be good supervision and good coaching across the board. That there was really nothing special or unique for the peer staff that didn't apply to everybody else, right? So the nature of the workshop, the 2-day workshop we do that we call Leading and Coaching, is really a very good workshop for everybody supporting any employee. Create job-specific peer support roles. This is really important. So one of the things that has happened in some states in the U.S. that have implemented peer support is they've added it in as a service to existing teams. Now, this is a good thing if you're a peer support specialist working on an ACT team. The question is, what distinguishes what you do from the case manager or the rehab specialist or the other members of the team? And in some places, it doesn't, it looks the same. Now this is a pitfall because if it looks the same, we're going to lose the value of peer support. We're going to lose the value of peer support on that team and the challenge, the conversation that the peers bring that's fundamentally different. And again, we were talking earlier this afternoon about some of the conversations that go on in the break room, you know, or in the staff meetings that are conversations about people we're serving that sometimes aren't so nice, right? If I'm a peer on your team, I may have been there 2 days ago or 2 weeks ago, and I've seen so many of our peer staff be so disturbed and distressed, and we support them to have that conversation. But we want peer support to really be peer support, and so we create a job-specific role and tasks for the peers. We also need to reach a tipping point, and I say it's a transformation tipping point because for us, the most powerful thing we've done in terms of creating recovery-oriented services has been changing our workforce and hiring peers. A critical mass of peer support workers, and we need to do this as quickly as we can. We put one peer out in an organization or in a team that has many, many, many other employees. Guess what? You know, they have to suddenly adapt themselves and quickly to that culture. We want to create a peer presence in the culture, so let's get a critical mass as quickly as we can. We also want a career ladder. What started to happen with us is as our peer support specialists gain more confidence and more comfort in their job role, they wanted to take on more responsibility. So if we didn't have that opportunity, they would go down the street and become a case manager, and all of a sudden all that they learned about their peer contribution was not as valued. So we created a career ladder where we have team leaders, we have program managers and administrators that are peers that are supervising peer staff. Parity for peer support workers. This is really, really important. So supervision and support, performance expectations, pay, promotions, ethics, it's the same across the organization. We don't make a distinction between peer staff. We don't do anything special. We expect the same things in terms of what we say is service productivity, direct service hours, attendance, documentation, ethics and boundaries. Same rules apply to everybody, and we've always got to remember that that's because this is real work, you know, and we had to learn this in the beginning because we wanted to cut some slack, you know. And we did that, and what we found was the peer staff didn't want it, and they didn't like it, and they said, stop that. You know, we're real employees, we're making a real contribution, why don't you treat us like everybody else around here? Another key thing of our transformation to create recovery practices was developing an education approach. We believed that education was more compatible with a recovery approach because it's about learning and growing, right? And it's certainly much more acceptable in society to be a student than a mental patient. So there's a valued role that goes along with it. So in 2000, we created what we called the Recovery Education Center, and we began to offer classes. First, we didn't know what to call this. You know, is it groups? Is it meetings? And we started listening to people. They said, no, well, we'd like to come to a class, but we've had enough groups, you know. So we created classes, and then we wanted to figure out a way that these things could have value. So we started talking with our local college system, and we were able to form a collaboration where these classes actually could be completed and people could get college credit for taking the class. And eventually this moved to a degree program in recovery where people could actually get something on their resume that had great value and improved their employability.